that you've attended, so thank you, thank you. Part of what I want to talk about and get in our heads is to think about a system of alternatives to incarceration. Not a program, not one or two actual activities, but a system of thinking, looking at the justice system, and how do we integrate public health into that system. An issue which, thank heavens, the UNODC and WHO have taken the lead on as well. Now, I have a friend in the audience, Dr. Igor Kostanok, who's talked about it as therapeutic justice, and I like that phrase because I think it really does help us understand what we are trying to do when we're talking about integrating the public health system, the social service system, the substance use disorder treatment system into the justice system. I'm going to use some data, and that data is going to come from the United States, but I suspect it's not very different than the data that you would see. But the question is, what is the nexus? Why are we bothering looking at the issue of drugs and crime? And I think if you take a look at it, you'll see that alcohol and other drugs are involved in 78% of violent crimes, 83% of property crimes, and 77% of public order and that kind of crime. So there's no question that when we look at the criminal justice system and who is coming in and going out, we're talking about people who have substance use disorders and other drug involvement. Now, if we don't care about their lives and about saving those lives, we should care about the cost. It costs a lot of money to deal with these individuals that come in and out of the system. And when we had to talk to policymakers in the United States, we tried to quantify that cost and say, look at how much we're spending on incarcerating people, on prosecuting people. And that was a way we said, maybe there could be another way of handling it. And also we said, if we look at the issue of what we know about substance abuse and mental illness and who is in our jails and prisons. In the United States, we have jails which usually mean local crimes, crimes that are of a less serious nature, and state prisons, which are crimes of a more serious nature. And we look at what is affecting those and who are in those in our jails and prisons versus the normal population. We talk about 64% of people with any mental health problem being in our local jails, 68% of people with substance use disorders. So we see that our jails and prisons are housing those of our community that are in need of some level of service. It is indeed a revolving door in terms of what is going on in the justice system. Let me get through that. 9 million people churn through the jails every year. 730,000 are admitted and released from prison. 2/3 of the prisoners are rearrested within 3 years of release. Think of that. 2/3 of those individuals. And half of those people who are returned to prison for a new violation. Now, there's a phrase in the United States that says, if in fact you keep doing the same thing and expect different results, you are crazy. It doesn't work that way. And yet, we, for many years, were doing that. Getting tough on crime, arresting people, putting them through the system. And guess what? We never saw any real reduction. And the cost, as I said before, was going up, up, and up. So when we think about what we are doing, we're talking about therapeutic justice as a process and method by which we integrate the public health approach to addiction into the criminal justice system. We provide an opportunity for treatment interventions along the criminal justice continuum from arrest all the way in and through incarceration and community release. We connect evidence-based addiction treatment and the justice system, and we facilitate the communication among public health treatment services and the justice system. That's a process of therapeutic justice. We do know some things. We know that the earlier that people are diverted out of the justice system and into treatment, the better their prospects will be. That in as few as 3 days in jail can significantly increase the likelihood of future justice involvement. That was an astounding piece of data when it came to me. And that outcomes for individuals who receive treatment are significantly better, obviously, than those who do not. We also know that it's important to be able to match an individual's risk and their social and therapeutic needs. That obviously the idea of the crime and the need to be weighed in proportion to what is going on, so that is part of the intricacy of dealing with therapeutic justice in building a system of alternatives to incarceration. I call it kind of proportionality. We balance the seriousness of the offense and the severity of punishment. We look at minimum levels needed to protect society. We look at suitable types of supervision and treatment. We adjust and terminate when appropriate that treatment, and we respond to noncompliance or breaches in treatment when we know for a fact that this is a recurring disease and relapse often happens, and how do you build that factor into a justice system that requires accountability? Luckily, we have the UNODC and WHO standards to also be a guidepost. And I know, Anja, that you will probably be talking about that, so I'm going to go very quickly through these. I don't want to do that. One, that treatment for drug use disorders should be in health and social care systems and should be in effective coordination with justice. That treatment of drug users should be available to offenders, and that drug use disorders as an alternative to incarceration should be supported by appropriate legal framework. We also know that criminal justice settings should provide treatment to justice-involved individuals within the community, that treatment interventions for drug use disorders should not be imposed against their will. We are not talking about people who are not willing to abide by this, because that won't do any good. Now, you may make them an offer they can't refuse. The offer in Chicago, for instance, when we first started, and I had to negotiate with the courts, their willingness to allow alternatives to incarceration was we would say to our clients, you know, this is the deal. We think we can get the judge to put you in treatment and in the non-community probation, but you're going to have to plead guilty to the crime. They didn't want to do that. Well, that's the deal. So the point being that it wasn't that we were saying you must go, but you have a choice here. And unfortunately, it's a hard choice, but it's the first hard choice you're going to make in terms of your recovery. And also that prevention and treatment services should be accessible to justice-involved individuals with drug use disorders. That we've got to train criminal justice system staff to make sure that they're supportive of this process, and that the continuity of drug use disorder treatment should be ensured. It is very important that we make the broadest range of comprehensive treatment available. Now, I like to put this all in a picture, and this is my favorite picture. I call this, and we call it in the United States, the subway map. It could be the train, it could be whatever, where you enter at the beginning at arrest, and if you're unlucky, you go all the way to the end, which is jail or prison. And then you come out. And guess what? If you're not in treatment, you come all the way back to the beginning again, and there you are arrested again. It occurred to me that perhaps I need to modify this to make it a more Viennese slide. The Ringstrasse, if any of you know the Ringstrasse, because I was there the other day, where you get on the trolley at one point, and if you're lucky, you get to go and see all around, and you come back right to the beginning. And that's exactly what this is about. So the question is, if we look at this system of justice, we see that there are stops along the subway or the Ringstrasse where indeed we could get off. And those are the points that we need to consider in terms of how we create alternatives to incarceration, one by one. And let me explain. Let's begin, for instance, I'm going to go right to this, with the idea of law enforcement. A person is arrested. What can we do? What can the police possibly do? Well, what we can do is a new word we're talking about, which is deflection. Rather than charge the individual, that the police can probably say, you know, I might have a deal going on with the local treatment program. Let me move that person. Let me take them to the treatment program. Let me take them to the detox center if they're going through withdrawal. One of the things that has been occurring in the United States, and that police departments have been really looking at this model, is because they constantly are seeing the same people going through withdrawal, doing overdose, having to save them. They've come in, they go out, they're seeing the same people, and they said, you know, arresting these guys isn't going to make us, we're not going to get anywhere. And so they've been able to develop relationships with the local treatment programs, with hospitals, so that they in fact can move people into, again, the public health substance use treatment system. In addition, some of the police stations have also said to the community, if you would like to stop using, you can come in, you can drop off your needles, and we will make a referral to a treatment agency. They've become very aggressive in working with the local community, and I think that's really exciting. The second level is to look at diversion at the prosecutorial level. This is where the arrest, the charge has been made, and the prosecutor now has to decide what to do with that charge. And there is a possibility of diverting that individual. In other words, let's not move it on to the court level. Let's hold that charge, and let's make an offer to the individual which says, if you will go into treatment and successfully complete treatment, we will not prosecute the case. And there are many, many prosecutors that are doing that. Now, of course, if we go back to my discussion of proportionality, the issue is, what is the nature of the crime? You are not going to find prosecutors that are going to do this with an individual who may have a criminal record of 10 previous criminal acts. It's just not going to happen. This is usually done with first offenders, potentially some lightweight second offenders. But we're talking about prosecutors who are using the legal framework they have to say, we're going to hold it into abeyance, we're not going to continue this unless you fail to live up to the terms of complying with treatment and successfully completing it. And of course, the third level is as the case moves along, in fact, to the courts, where we're now dealing with the individual, the case, and what will be happened in terms of the actual sentence involved. Now, I know that we all understand and know drug courts, but I just want to put a word in to suggest to you that one of the things that we always have to be careful of is that if we set up a system with one drug court in a community that may be seeing 10,000 individuals, 5,000 of whom have property crimes that may be related to substance use, one drug court's not going to deal with a systemic impact. So it may be possible that the kinds of activities that go on at a drug court, which might be diagnosis, case management, et cetera, ought to be available across the criminal court continuum. In other words, judges who may not be drug court judges ought to have access to those services. However, and having said that, drug courts are often a wonderful way to introduce the justice system to therapeutic justice, to alternatives to incarceration. So I would suggest that. Then we have the issue of, okay, well, there are people who go on probation in our system in the United States that are not incarcerated, they've committed a crime, they've been found guilty, and they're put on X number of years of probation. And oftentimes the court and the prosecutor will have missed the fact that this is a person with a substance use disorder, or the disorder will in fact kick in when the person is on probation. So our probation or community supervision people need to be available in order to refer to treatment and to minimize the recidivism that often happens in community supervision, because people become, their substance use disorder becomes more active, they have technical violations related to it, and rather than automatically send people back to court to be sent to prison, we put them in treatment. The idea of some treatment within the jail and prison system is for some countries possible, for others not. But one of the things that we find that is absolutely critical is in those countries where in fact there is some therapeutic justice. It's often performed by a contract with a community treatment agency, if not the medical and psychological staff of the jail or prison itself. If you do not have a reentry plan for when that individual leaves, quite frankly, you're wasting your time and money by putting the therapeutic program in the jail. And so the idea of reentry, or as my friend Antonio Lumba likes to, social reintegration, is critical here. The idea that there is referral to the community treatment center, continued treatment interventions, and treatment compliance has to be continued. So those are some of the factors, and those are some of the stops that are necessary for us to look at ways in which we can get off the subway before we end up at the very end incarcerated. Now, the trick of it is that, okay, we have an exit sign and we want to get off. Well, the individual is, okay, out the exit, but wait, who's meeting that person? Well, this is where the connection is very important, and we're calling that case or care management, because it is in the case or care management process that the individual begins to be seen as the patient. And we have a case manager who can deal with the point of entry, with stabilization, with dealing with the crisis, moving to referral to treatment, monitoring that treatment, and even more than that, making available further resources, the social and economic supports which are necessary for real social integration. So case and care management, it's kind of like, I remember I was on a tour once, and the tour bus or the plane or the train would stop, and there would be the tour guide. And he would have my name, and out we'd come, and he'd take me, and he'd put me where I needed to be, and got me on the bus, and he would show me the sights. Well, I call our care managers the tour guides. They will and must help move this person into the appropriate levels of treatment, make sure the diagnosis is correct, et cetera, et cetera. Part of also is the idea that they then help develop the treatment and social rehabilitation plan, absolutely critical to this. They facilitate the connection to the necessary social and primary care supports as needed, and they provide patient support throughout the treatment process. We know how critical that is. We know that recovery is a long process and needs supports, and the case manager has to be someone that can develop a supportive relationship with the client or the patient as they move through the justice system as well as through their own recovery. I think there are some basic elemental criteria that are necessary if we're going to have a successful system. These are what I call the top three. They're so basic, but they're absolutely critical. One, it is absolutely necessary that you negotiate the procedures and agreements between the treatment agency, the case manager by that, and the justice authority. When we started TASC in Chicago, Illinois, it was to provide alternatives to incarceration for individuals that actually had some very severe criminal histories. And I sat down with both the court and the probation office and literally negotiated a procedure from the time we were given the name of an individual to the time that person went to treatment and what else happened, so that they knew exactly what our responsibility was, they understood what their responsibility was, and there wasn't any surprises. It's also important, and this is sometimes more difficult because of resources in our community, that evidence-based treatment systems have the adequate capacity across modalities, from outpatient to inpatient, residential, medication-assisted treatment. Now, admittedly, this is the gold standard. But if we are going to deal with this population on a systemic matter, and we're going to make the impact, inevitably, we have to build a capacity in a treatment system that allows individuals the most chance of success so that we are meeting where they are in their substance use disorder and in their social and other therapeutic needs. And we also have a clinical case management system that has the ability to report back to the justice stakeholder. The court, the justice stakeholder, has to believe that they can trust the case management person, the tour guide, to tell them that that individual is complying with treatment and making progress in their recovery. That is a critical component in getting the justice system to believe in the need and the use of therapeutic justice models and alternatives, and getting the confidence in their ability to expand those. One of the things, that, however, that's become sometimes a problem is, what do we say to the client? I'm going to be there in the very beginning, and I'm going to advocate for you as an individual who needs to be in treatment versus incarcerated. But I have to tell you that in the end, if you do not comply with your recovery, you're agreeing to it, you want to do that. If you're not going to agree with that, then frankly, we will be back before the judge and tell him. So we cut the deal with the client, and we even had and still do, a written agreement with the client, so they know the rules of the game. And so in my mind, we're talking a communication system whereby the justice system knows the rules, the treatment system that we're sending individuals know the rules, and the client knows the rules. So there's no surprises in the game. That is, in fact, perhaps the skeleton of what we're talking about when we're talking about a system of alternatives to incarceration. And I encourage you to start wherever you are. It may be in a drug court, it may be in a probation, it may be with a prosecutor, but to think that as that is the beginning of your perhaps marketing through a successful building of that relationship to the rest of the justice system, so that indeed at every stop along the way, we have a tour guide to take that individual and move them into treatment and expand their recovery. Thank you.
Melody, thank you so much. I just wanted to make just a comment from our office, from the U.S. State Department, that we support many international organizations, and we're supporting many different training events here at ISSUP this week through Colombo Plan and the Organization of American States and the United Nations, and we're doing lots of treatment and prevention training. But I hope in the future that we can also do alternatives to incarceration training. And so I want to And so I will announce 2 different training courses that we are almost done working on. One is a 2-day Alternatives to Incarceration course for policymakers, where countries can come together with their public health and their criminal justice system folks. So it's the judges, the prosecutors, the psychologists, sociologists, the law enforcement, everyone on that continuum of care, that subway train that we were talking about. And talk about all these different types of alternatives, give you an overview of what are all the different options that are available. And then the second day is really action planning. Where do you want to get started? And that's good even if you already have drug courts. Where do you want to go next? Do you want to look at pre-diversion? Do you want to look at reentry programs? And it gives you an opportunity to kind of brainstorm and think about that with experts that are trainers. And there's also a law enforcement official and also a public health official, and usually a prosecutor or criminal justice expertise in the course. So that's how when that's going to be done. We've already pilot tested, and it's going to be done at the end of this year. So that'll be available. Next year, we also hope to have a case management course that is being developed by the Organization of American States. And that one will look at how do you develop a system for case management. Melody was talking about is really the importance of having a case manager to help that person not only with the actual court system, but also how do you access all of those different various treatment points and make sure you're getting proper screening and appropriate care. So I just wanted to make those 2 points. Next, we're going to have Anja Busse from the United Nations Office on Drugs and Crime present on why treatment is so needed in the criminal justice system. Thank you, Anja.
Thank you so much, Charlotte. And actually, I also really wanted to thank Melody for the excellent presentation. And you hear, I would say, maybe a lot of the similar arguments what Melody has put forward also from me. What I wanted to kind of invite you maybe to take home from my presentation, I'm putting forward some arguments, how we, for example, enter into discussion with policymakers and countries when we want to start talking about offering, the possibilities of offering treatment and care for people with drug use disorders that are in contact with the criminal justice system as an alternative to conviction or punishment. And you will be surprised that actually in a lot of countries this is not much available, right? And so let's see. And I mean, all of this is based on a document that we launched at the CND in 2016. And I'm very happy to see a lot of people, both on podium and here in the audience, that actually have been developing this document with us. I'll encourage you to read actually the document, because what I can present here is just a snapshot, which is more or less talking about the, as I said, the rationale, the why doing it, and maybe a tiny little bit the how we approach it, but of that you've also heard a lot already from Melody. So, but the why and the how, I think also the question is at the same time, to situations like this, what is the response that we as society, as international community, as leaders in your countries, what is the response that we want to give, right? And is sometimes this idea of cleaning the streets and putting everybody into prison, or maybe there's something that's more effective and in the end is better for both public health and public safety, and that's, so to say, really the rationale or the argument behind, or the discussion that we try to enter in. So, but first of all, also it's very important just to realize that many people with drug use disorders are in contact with the criminal justice system at some points in their lives, and vice versa. A lot of people in the criminal justice system actually have a history of drug use or drug use disorder. So just that kind of makes us think about this health justice interaction. And we know that at any given day worldwide there are roughly 10 million people in prisons, and that on the other side, looking at not from the prisons but from the drug use situation, about half of the people who inject drugs will be incarcerated one or more times during their lives. So we have this interaction, as we said. But we also know that drug use doesn't end in prison. So while, and Kamran is here, our World Drug Report kind of expert, well, we know kind of that roughly 5-6% kind of maybe is the global prevalence of drug use in the community. In prisons, we have rates up to 20%. So, and in addition, prison is associated with higher risk, for example, for infectious diseases. There is overcrowding, there's a lack of access to health services, and so on. So from that perspective, again, think of the picture that we saw in the beginning. What is the response we want to give, and why, and how effective comes in prison. So, but then one of the arguments is that actually offering treatment as an alternative is an effective criminal justice strategy. So it helps to reach the goals kind of criminal justice side policymakers and practitioners. I mean, we know, and this is a more generic document from the UNODC justice section, that there's very little evidence that increasing imprisonment actually improves public safety. So it doesn't help us much with public safety, putting everybody into prison. And we know on the other side, and it's quite self-explaining, that alternative strategies that divert people to other services, health services maybe, or social services that can benefit them better, might actually be more effective for both health and safety aspects. And the other thing, which is very important also when talking to policymakers that usually unite very much in this room, that prison is a very expensive kind of measure. So also when we think of public spending, it's good to think what are the alternatives. So, I mean, and Melody has said it so much, and we will look at kind of some of the studies, how accessible and attractive treatment actually reduces criminal justice contacts for people with drug use disorders. So it goes beyond the health outcomes. This is actually a very old study, I think one of the first methadone studies ever done, and it could show how pharmacological treatment, evidence-based pharmacological treatment could help reduce reincarceration. Evidence-based treatment can help kind of reduce rearrests. And this is also US data. But this is also interesting because there's an association between investment in treatment and crime reduction in a community, right? So, I mean, this is a very important argument when talking to people mainly concerned with public safety, which is a very valid concern, right? So treatment is effective there. And treatment affects involvement of criminal behavior in individuals. So people kind of in treatment have been less involved, and much less, as you can see in these also US data, in, for example, selling drugs or in other ways of being involved with illegal activities. And treatment improves the quality and of life of the community beyond, so to say, so we said crime reduction, which is one thing, but also other points, like there's less need of welfare, homeless rates can be affected through investments into drug treatment, and or employment rates can go up. So all of this is something what we would want for our communities. And this was mainly US data, but this is, for example, a study from China that actually showed more or less the same, that community-based treatment could reduce the crime rate, could have a positive effect on employment rates, and so on. So this kind of the talking to, let's say, the justice system, but of course we're also talking to the health system, right? We're also interested in the health of people. And we've heard this morning about the international standards for treatment of drug use disorders, which are listing effective interventions that actually can help us reduce the harms associated with, but also drug use as such, and increase chances for recovery and a life in quality and dignity for people with drug use disorders. So we have the tools also to affect health in a positive way through treatment, but also think that treatment is cost effective. So there are estimates, this is a very, let's say, gracious one maybe, that for every dollar spent, after $18 can be saved again. So we are talking to the pockets of people that are in charge of public money. So we can save costs in terms of reduced incarceration rates, and remember we said prison is expensive, and associated crime and criminal justice costs. This is the same slide, kind of saying very much the same, or comparing, so to say, how incarceration, which is the second from the bottom line, is much more expensive or costly than other forms of drug treatment. But one thing also very interesting in this slide, that the most expensive thing is doing nothing. Untreated addiction, not doing nothing, you're also taking a decision, so that's also important to keep in mind, because of course there will be costs in the health system, in the criminal justice system, and so on. So other thing which I think is very important, we offer as an argument, and also when you go back to all of your countries, and especially coming from this room, and I can't stress it enough, that's where the Commission on Narcotic Drugs meets, right? So countries are sitting here in alphabetical order. Treatment, let's think about it, treatment as an alternative, and how does it relate to the international legal and policy framework? So who of you knows that there are international drug control conventions? Hopefully some. Okay, yes, okay. So, and then let's think, is it actually that the drug control conventions consider drug users as criminals that need to be punished, or things like that? And well, you guess it, it's a rhetoric question a little bit. So, because actually what the international drug control conventions say, and that means that all countries that are parties to the conventions, and that are basically all countries in the world, basically have taken a commitment that the parties, so the countries, shall take all practical measures for prevention of abuse of drugs and for early identification, treatment, education, aftercare, rehabilitation, and social reintegrations of persons with drug use disorders, right? So, but then if people with drug use disorders, in addition coming in contact with the criminal justice system, all of these measures that I just listed can be applied either as an alternative to conviction or punishment, or in addition to conviction or punishment. So the conventions leave this flexibility and put it on the member states, but keep in mind that the conventions very much allow that these measures as above, like treatment, education, and so on, in cases of drug consumption offenses and cases of drug trafficking of a minor nature, can be applied as complete alternatives to conviction or punishment. So the conventions kind of allow very much for the consideration of treatment as an alternative to conviction or punishment in adequate cases. So, and this is just kind of to get a little bit you thinking, right? So in cases of possession, purchase, or cultivation of controlled drugs for non-medical use or consumption, can actually, in the case of people with drug use disorders, can an alternative be offered, or do we need to have treatment in addition? Who thinks an alternative is possible? Can I get a hands up? And who thinks it needs to be offered in addition? Okay, maybe it's also a bit confusing. Let's go actually to the next slide. So, I mean, in reality, as I said before, I mean, for everything which is considered an offense of a minor nature, treatment can be offered as a complete alternative to conviction or punishment, always with the caveat that it's up to member states, you know, if they want to use it in addition, but it cannot be in a way blamed on the international drug control conventions. I mean, one case where it's very clear, it's large-scale drug production and distribution involving violence or organized crime. Obviously, there's going to be a criminal sanction, and if such a person nevertheless has a drug use disorder, well, then we need to offer treatment, but likely in a prison setting. Also, I wanted to remind that in addition to the international drug control conventions, there is a broader international legal framework with standards and norms, some coming, for example, from international human rights law, kind of reminding us of the need for due process and so on. But also very important, the Tokyo rules and the Bangkok rules. Who has ever heard of the Tokyo rules and the Bangkok rules? Can we get a hands up? many people, or some at least. So the Tokyo Rules and the Bangkok Rules are both documents that have been approved by United Nations General Assembly, so they have a high support from international community. And the Tokyo Rules are the United Nations standard minimum rules for non-custodial measures, and the Bangkok Rules look at non-custodial measures, especially with a perspective on women. So the Tokyo Rules, for example, right, it's a much longer document, kind of highlight the importance of non-custodial measures being offered in the community, right? So not necessarily in closed settings, but think about it in the community. And that we need diversity. So not everybody will benefit from the same alternative. Let's think about a diverse range of alternatives. We still need trained professionals to offer these alternatives. It's not enough that whatever a former prison guard now is offering drug treatment. People need to be trained to do these things. It's also important to understand always the offender's background and situation. And I think the last thing is also very important, which is coming out of the Tokyo Rules, that the failure of one non-custodial measure does not necessarily mean that now automatically there needs to be a custodial measure imposed. So we can also try, as it says with the diversity, maybe another alternative measure that might work better. So in terms of gender-specific alternatives, most jurisdictions do not have gender-specific alternatives to imprisonment in place, even though we know that most women that end up in contact with the criminal justice system have committed rather non-violent offenses, so they would actually qualify very well also for benefiting from alternatives to conviction or punishment. And for this purpose, kind of to this speak, the Bangkok Rules, or the UN Rules for Treatment of Women Prisoners and non-custodial measures for women offenders, and they're looking at especially gender-sensitive non-custodial measures, such as considering the background and the family ties of the women, who very often maybe are the ones that have to provide for the family, and also to think of what's in the best interest of children. And they go on kind of also highlighting what we heard in one of the earlier presentations today, that women and women with drug use disorders maybe more often even are also affected by trauma and might need additional assistance also in this regard. So take home really is, from the international standards, Tokyo Rules, Bangkok Rules, but also again, the special session on drugs of the United Nations General Assembly in 2016 spoke to the need to consider the multiple vulnerabilities of women drug offenders. So the policy framework, in addition, is there. So just to recap quickly these 4 points, we've looked at what are the arguments we can give to the criminal justice system, how is it, and therefore to public safety, how is it speaking to public health, how is that kind of in the view of the international legal framework. And now just a couple of words kind of on the how, but I think Melody has in reality already said it so beautiful. I mean, one thing also, because we are coming from a global perspective, we always have to be very mindful that, of course, every country has a different legal system, and it needs, and maybe also a different treatment system and health system, and we really need to understand well what works in a certain situation and where to start. And I think, Antonio, for example, you're also kind of doing this a lot, right? To understand first what's the situation and then to move on. And at one point, also Melody mentioned that this interaction between health and justice is so important so that we understand. I mean, and for me, I have to say this exercise of working on this, I had to learn so many words and understand really what is probation and non-custodial, this and that. But at the same time, also my justice colleagues kind of had to start learning about what actually is psychosocial treatment, what are you doing there. So it was a very good process. But it's not only at that level. There's a resolution of the Commission on Narcotic Drugs that asks for health and justice sectors to work together. And how to start, also another thing, how you were saying, kind of to use the flexibility in the existing system, and that's something we very often encourage also when we start working with countries. It does not always need a constitutional reform or something. Sometimes there is flexibility in the local legal system, but maybe the justice practitioners are a bit worried. They don't want to, or they don't dare kind of using this flexibility because they think, what's going to happen if I don't send the person to prison? I send it to treatment in the community. But that, of course, well, and here, this is maybe hard to you to read, but basically this slide kind of speaks to the same what Melody was saying before. So in principle, and we've mapped that also out from responses that we received from countries that we reached out to. In principle, alternatives exist along the criminal justice continuum, from pre-trial, during trial, but also post-trial, for example, early release or so. One thing maybe which we have added here, which Melody maybe hasn't mentioned so much, is there are also administrative sanctions that can be considered as an alternative to conviction or punishment, but there's a little bit of caution to be kept in mind, because sometimes administrative sanctions work very well, but sometimes there is also a risk, because sometimes administrative sanctions do not have the same legal safeguarding as maybe the criminal justice sanctions. So there might be less possibility to appeal or so against an administrative sanction. So just to keep in mind that there is the continuum kind of from administrative sanctions, pre-trial, trial, post-trial. But all of this, and I think that Melody also beautifully said, in reality, all of this depends on a network of evidence-based drug treatment services in the community, because where, other than that, are the justice professionals are going to divert people with drug use disorder to, if they are, if there is a flexibility in the law and they want to offer alternatives to conviction or punishment. This maybe I skip for sake of time, just to let you know that beyond the document, we have also considered working. So we have, for example, been going in 16 and 18 to countries like Cote d'Ivoire and Kenya, and also in this regard, maybe to mention that the African Union has been very much part kind of the group developing, and you're also working kind of in the same direction. So what we did was actually not rocket science. We very much brought together health and justice practitioners and kind of gave a platform to exchange, to get to know each other, but also kind of they were agreeing on actions to take when they leave from there. Another thing that worked quite well is actually that we took the whole group, for example, to a drug-using site, kind of a slum area in one of the cities, and afterwards to a treatment center, and that helped very much also build this mutual trust between health and justice practitioners on one side to see the reality of people with drug use disorders, but also kind of start building this trust in what the treatment system can actually offer. So just closing all of this, just let's think again, what is it that we would like to offer to people with drug use disorders, very often in very marginalized situations. And I think we had years before a document that was called From Coercion to Cohesion, and that's somehow the slogan, maybe we want to give you home. So we want to move from a sanction-oriented approach to an effective health-centered focus, but not only because we are so good people, right? It's also because it benefits at a very rational basis, both public health, but also public safety. And this is hopefully something you can take home also to your countries when you enter in these discussions with policymakers. UNODC, both on the health side and the justice section here in Vienna, happy to help you. Just reach out to us, and this is how you can contact us. Thank you very much.
Thank you, Anja. And thank you for testing us on our UN conventions and the Bangkok and the Tokyo rules. I think that was a real quick guide if none of you have seen any of those materials, that all of the work that the countries have done is really important as a baseline to work on alternatives to incarceration. I also wanted just to comment that I think we've all said it, and I think we'll keep saying it, is it really is, and I like the way Anja said it, that, it's not just the criminal justice system having to learn about public health, but the public health also having to learn about criminal justice. I'm not a doctor or a lawyer, I always tell people that, and it's hard to bring up all of those criminal justice terminologies, but really it is about understanding the different places where we can get people into treatment, and that's for nonviolent offenders. Next, I have the pleasure of introducing Roger Peters. He is a professor at the University of South Florida, Department of Mental Health, Law and Policy, and he's going to give us an overview of co-occurring disorders within the criminal justice system, which really adds more complexity to this issue. Thank you, Roger.
Here we go. Terrific. Nice to be here this afternoon. And kudos to all of you sitting here in a darkened room after lunch for the late afternoon session. I'd like to also thank ISSUP and UNODC and the other conference partners for putting on a great conference. As Melody and Anja have discussed, a cooperative and systemic approach is really needed to address the population in the justice system who have substance use disorders and to divert these people from punitive dispositions and particularly incarceration, which is incredibly expensive as we've seen. Even with that comprehensive and systemic approach, though, I think that there's a group of persons in the justice system who are often overlooked and who receives, I think, substandard care. And that is a group that has co-occurring mental and substance use disorders. And so I'd like to talk a little bit about this population and how we need to address this in particular throughout our systems of care in the justice system. And we're talking here about at least two disorders, a substance use disorder, typically moderate or severe in nature, and then a major mental disorder, and these are examples of the major mood disorders, bipolar disorder, or the psychotic disorders, which I think are the most impactful in terms of influencing functioning for people who otherwise could be treated in standard substance abuse treatment programs in the justice system. Typically, though, people have multiple mental disorders as well as multiple substance use disorders. So we're really talking about poly disorders of each type. Just very quickly with this population, some things that I like to highlight. This is a rapid cycling population through the justice and treatment systems, and they're quite expensive, as both of our previous speakers have talked about. They experience particular problems when they're not in treatment, when they're not taking their medication, when they're using alcohol or drugs. And even small amounts of alcohol or drugs creates major problems for this population that's somewhat different from other clients or patients that we would see. And I think that alcohol or drugs provide a destabilizing effect on this population who may lose their housing. They may lose contact with their families as a result of using even small amounts of drugs that may aggravate their mental conditions. And so we have to change and adjust our levels of concern for even moderate amounts of use among this population. We also know that this is a group that doesn't fare well in the justice system. They serve longer sentences. They are 3 times as likely to be victimized in detention or prisons as other individuals, or to be perpetrators of violence for others. When they're placed in solitary confinement, often as a result of their behavioral problems related to the mental disorders or detoxification as it may be, they worsen both of their disorders, but particularly the mental disorders. And so it may take a year or longer for them to recover from that, and they may be transported back and forth to different facilities to no end without a coordinated system of care. And as mentioned previously, this is a group that has incredibly high rates of reincarceration that are very expensive. And so I wanted to share with you an example from where I live in Tampa, Florida in the US, of an individual over a 10-year period who has co-occurring disorders, who has been homeless for most of his career in contact with the justice system. And you can see at the very start on the left-hand side, this is an average-looking person to begin with his initial contact with the justice system. It could be somebody you see on the street in Vienna and wouldn't think twice about that. It could be somebody you see at the beach in Florida where I live. As you move forward, he looks more like a person from a bicycle gang, a motorcycle gang, or someone who's a threat and dangerous. And you can imagine meeting somebody like that on the street on the far right after 10 years being homeless and cycling through the justice system, the impact that it's had on his health and so forth. And so we need to come up with solutions for this population. This is hard to read, but I just want to give you a quick summary. This is a summary of just some of the arrests over that 10-year period. There are 28 arrests here. He served almost 900 days in detention locally, sometime in prison. This cost $113,000 US. over the course of this period of time, and there was no good solution in terms of providing community dispositions with specialized services for his co-occurring mental and substance use disorders. So we can do better, and we have to do better with this population. And unfortunately, this is a group that's overlooked and oftentimes placed in levels of care in which the staff are not trained in both sets of disorders, and we assume that they can benefit from traditional treatment when in fact that's not the case. We have dismal, very poor outcomes in traditional mental health programs and traditional substance use programs if we don't attend to both disorders in an integrated fashion at the same time. So these are rates of the disorders. I will skip by this pretty quickly in service of time, but as you can see, the rates on the right-hand side, both in detention and in prison for both men and women, are somewhere in the neighborhood of 4 to 8 times the rates of the mental disorders in the general population. Less than a third of persons coming into the justice system with these mental disorders are actually taking medications at the time of arrest. And they have a much greater rate of history of incarceration in relation to other prisoners. Some of the specific mental disorders, without going into great detail, we see that in some cases we have almost 20 times the rates of bipolar disorders, for example, as compared with the general population, 10 times the rate of psychotic disorders. The bottom example, I think, is a vast underestimate, because we know that approximately 75% of females in the justice system have a history of trauma, as well as actually about half of men have a history of trauma that result in problems that need to be addressed in treatment. So, for those with mental disorders, what are the rates of co-occurring substance use disorders? Well, it turns out it's 74% of individuals in the justice system with a major mental disorder have a co-occurring substance use disorder. That's incredible. We can almost assume that if we have a mental disorder in any of our justice settings, that we have a co-occurring substance disorder present. If you look at the right-hand side of that graph, those are individuals without mental disorders, and we have over 50% of them who have substance use disorders that need treatment as well. And so it's just a magnified set of substance use disorders for people who have a major mental disorder as well. So what does that mean for co-occurring disorders? Well, it means that 23% of our people in justice settings who are female have a co-occurring disorder. It means that approximately 11% of males in our justice settings across the board have co-occurring disorders. One of the first steps, as mentioned by Anja and Melody as well, is to provide universal screening for these disorders. And for me, it's shocking. When I travel, if it's in the United States, visiting programs, many of the programs provide inadequate screening for one or both of the disorders. Particularly when you get down to trauma and post-traumatic stress disorder, this is uncommon to have a systematic approach for screening that's evidence-based for these disorders as well, despite the very high numbers in our settings. Also, criminal risk or risk for future arrest is oftentimes not addressed adequately. And these are some of the independent risk factors for arrest. I won't go into detail with these, but you notice that mental disorders are not an independent risk factor for arrest. However, individuals with co-occurring disorders have high rates of these other risk factors, and thus they are more likely to be arrested than other individuals. I'm going to skip over this slide. Basically, this tells you that only about 4% of arrests among people with mental disorders are due to the mental disorders themselves. And so I think there's a big myth, isn't there? That people who are mentally ill, have mental disorders, that's what causes them to be arrested. That's not the case. And so I think a couple implications for treatment in the justice system is that if you just focus on treating the mental disorder, you're not going to have good outcomes. You have to address these other risk factors, including substance abuse, including employment, education, family supports. I think the other important implication is that all justice programs that deal with mental health need to be co-occurring disorders programs, and that includes mental health courts, units in prisons and detention, community programs for offenders who have mental illness. The good news is that we have a range of evidence-based treatments for co-occurring disorders that have been applied successfully within justice settings. And I won't go into detail. We could spend hours on this, but we have quite a range of these types of treatments that have been adapted for justice settings. For example, on the cognitive behavioral treatments, one of the focus areas for the justice system would be working on criminal thinking or specific criminal thought patterns that lead to arrest and re-involvement in the justice system, and substance abuse as well. There are many program adaptations for programs that are existing in the justice system that would like to deal successfully with co-occurring disorders, and I won't go into detail. These programs are typically a third longer than a traditional substance use treatment program. They have duly credentialed staff. The pace of treatment is slower. The range of issues is more complex, including the interactive nature of the disorders on things like relapse, for example. There's a focus on motivational interventions, particularly at the front end of treatment, where we might have things like engagement and persuasion groups for people who are not even believing that they have a major problem with substance use or with their mental disorders. And of course, this group also has a huge set of issues with housing, employment, and medication adherence. Finally, I'll leave you with this. There's good news about the outcomes of programs for offenders who have co-occurring mental and substance use disorders. If you look at the left-hand side, this is a one-year reincarceration rates for prisoners with co-occurring disorders. You provide traditional mental health treatment in a prison setting, and you have about 33% recidivism, reincarceration, over a one-year period. If you provide a therapeutic community that's focused on co-occurring disorders, you can drop that rate in half. And finally, if you provide intensive treatment in the prison for co-occurring disorders and provide aftercare treatment of the same type that's a therapeutic community for co-occurring disorders, you bring that recidivism rate down to 5%. So we need more good data and research on this population, but I encourage you to think about this as a group that's underserved, that needs specialized attention, specialized services in the justice system. Thanks very much.
Thank you, Roger. Thanks so much. I just wanted to make one comment on his presentation, that the importance of screening within the criminal justice system at arrest, at pre and post jail, upon reentry, to always recognize the individual as a person and develop the appropriate level of care that they need, and whether that is cognitive behavioral therapy. I like the way some of the different types of things that you would do for mental health really kind of overlap maybe a little bit with what you would do with somebody with substance use disorder. You're changing behaviors, but you have to do a little bit more with mental health.
Charlotte, can I come in?
Yeah, and before I close, Melody would like to say one more thing.
I actually just want to add to what you
Sure.
just said, because I neglected to talk about screening. I think it's very important to understand there are two levels we're talking about. Screening, which is that initial look at the population and who may or may not have substance use disorders, but to be able to screen to identify those who do. But the second stage, which is absolutely critical, that a case management system working with the justice system would have, is the diagnostic capability. What is the nature of the disorder? Is there a co-occurring process, et cetera? What would be the recommended treatment plan? So there are two levels. There is the initial screening, and then there is the diagnostic process.
Thank you, Melody. We have 1 minute if there are any burning questions. Otherwise, we will all be here if you have other questions. But I wanted to ask the room, are there any questions that anyone would like to ask this panel while we are here?
Way back there.
I've got one here and one back. How about we start with you back there? Do we have a microphone? You press your button. Even better.
Okay. It's a quick question, really. Just wanted to know, do we know how many countries, if we have on average, have signed up to the Tokyo and the Bangkok rules?
So I'm not 100% sure, but both of those have been approved by General Assembly, so basically all.
Okay.
Great. And then in the front here? Okay, so we've answered everyone's questions then. All right, well, if there are any more questions, I'll give you one more. We have time. Oh, wait, we have another question? Just use your microphone.
Just a small question, actually two questions, two small ones. One is that are you aiming at targeting this, the alternatives to incarceration on the young and the youth, the younger people in particular? And secondly, what is the acceptance levels? How would the communities react to this? Is there some sort of a public opinion on not putting people, not incarcerating them and letting them out in the society? How is it acceptable to the community at large?
The first question, I believe, is do we have alternatives for young people?
Or is the program focused on the young people? Would you
Or is it
target
focused on
them
young
more?
people?
Yeah.
Roger, I'll let you deal with it. Or Anja? Yeah.
Also, I think we have to be very careful, and I have to say that the work we did on treatment as an alternative to conviction or punishment, we basically looked at adults. And why? Because in reality, for young people, we need much more safeguarding, and it's a total, let's say, much more of a protection approach even than from what we have talked here. So I have to say, for me, I would need to kind of look into it much more in detail, but it's a separate kind of approach where you think even much more about protection when it goes into juvenile justice.
And I'll just add to that too, and Igor would also like to mention something from the floor, that it really is a vulnerable population, and kids are very, they really need to be with their families, right? So some people have, children in the United States have actually escaped from prison because they want to be with their families. They need structure, right? A lot of kids need structure. So there are drug courts for juvenile drug courts, and they have that intensive supervision and care of the judge, and they go home and they have outpatient. But then they also, when they're done with all of that intensive care that they have just gotten, then they're back again to their normal setting. And what some they have done is they've instituted a mentoring program so that when the juvenile is released, they still have that mentoring support. So they still have support when they're released back into the community after they've done the drug court program. But there's a lot of science still out there. And I agree with Anja that I think this is an area where we need a lot more research. It's a population that is changing a lot. And I'll let Igor, did you want to say something?
Just a brief comment. The effectiveness of treatment interventions for justice-involved adults, if these programs are mechanically implemented in adolescents, usually the result is a failure. Children are not small adults. These are completely different creatures. But there is a lot of science focused on juveniles under criminal justice supervision with some substance use involvement, rarely dependence, but some involvement already. And there is a number of quite effective programs that have very solid empirical support of effectiveness. But the bottom line is what works for adults does not necessarily work for children. Typically it doesn't.
The other part of your question had to do was, as I remember, the community's reaction to this program. That is really a very, very good question and a very delicate issue, because many communities do not want those offenders walking through the street again. And so part of the sophistication of those of you who are going to be developing these alternatives to incarceration are to keep in mind there is a public relations quality to this. And so you have to be careful in the beginning that you create a system that you will be able to prove has actually reduced crime. So that you don't want to go full-blown, and I'm looking at Igor for you to comment if you think I'm going off base here. That you don't want to go full-blown to try the most risky, in a community that may be very nervous about this, to try the most risky, at-risk clients, highest criminal, et cetera. You may want to build toward that, but you begin with those who perhaps are a less risk profile, ones that particularly you think have a greater chance of accessing and moving into recovery. But the point is you have to be sophisticated about it. You have to think about the community and political reaction, and that justice system's ability to gain more and more confidence in you and your ability to help them reduce the recidivism. And that, it's interesting.
Well, I just kind of wanted to come back very quickly to the question on young people, and while, you know, really juvenile justice is not my area of expertise, so I feel, but I mean, we have heard in presentations before, and in reality, the idea is what can we do before the contact with criminal justice takes place? And you've heard that, for example, the family skills prevention programs are very effective when it comes to preventing both substance use, but also kind of engagement with, you know, crime, violence, and so on. And also I'm looking at Jose Stapochnik, who we have here in the room, and who's kind of one of the developers of brief strategic family therapy. Also, we are developing currently a model of family therapy, kind of under a UN logo, which we are looking at for both kind of treatment of adolescents with substance use disorders, but also kind of for benefits across the board, right? Again, kind of criminal justice involvement, you know, all of this. So I think, you know, we have very strong tools also outside of the criminal justice system to work with young people either at risk of or already kind of engaged with both substance use and crime.
Answer your question? Yes, great. I'm going to go ahead and close so we can take a break, and then we'll have our next panel. I hope everybody comes back to hear more about alternatives to incarceration. We could talk about it all day, obviously, but you can please come up if you have more questions. Thank you.